Assalamu alaikum. Assalamu alaikum, everyone. Thank you so very much, all of you, for joining in. I'm Dr. Azra Rizwan, and on behalf of the Pakistan Endocrine Society and the South Asian Obesity Forum, I welcome you all to this webinar on thyroid and obesity. So the World Thyroid Day is observed annually on May 25th to raise awareness about thyroid conditions and its associations with other disease. So basically the thyroid gland, as most of you know, is the fundamental organ that controls the metabolic processes of the entire body. In this connection, we are very lucky to have Dr. Musarrat Riaz, who is working as director and consultant endocrinologist at the Dow University Health Sciences, Karachi. She also holds the position of publication secretary, Pakistan Endocrine Society, to enhance our understanding of the relationship between the thyroid functioning and obesity, as both these conditions are increasingly being encountered across the globe by healthcare professionals. So following this would be a discussion with our esteemed panelist, Dr. Sadia Salman, who is an associate professor, medicine and endocrinology at Fatima Jinnah Medical University. And she is also a consultant endocrinologist at the Saira Memorial Hospital, Lahore. She also holds position, Dr. Sadia also holds position of General Secretary of the Pakistan Endocrine Society. So without any further ado, I would like to first start with the Tilawat-e Quran before I hand this over to Dr. Musarrat for her talk. So if we can have the Tilawat-e Quran on, please.
Bismillahir Rahmanir Rahim. Qul huwa Allahu ahad. الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
The video is stopped, the recitation is stopped in the middle.
I think it's completed.
Okay.
The recitation did complete or did not complete?
No, it's completed, right?
All right. Okay. Right. Thank you. Without any further ado, I'd like to hand this over to Dr. Musarrat Riaz to give us a talk and enhance our understanding about this complex relationship between thyroid disorders and obesity.
Okay, thank you so much. Thank you, Dr. Azra, and thank you to Pakistan Endocrine Society and SOF. As you have rightly mentioned that May 25 is celebrated as World Thyroid Day. As you have also mentioned that thyroid, it's a complex disorder and associated with so many comorbidities, and the knowledge of it's very important if you want to treat thyroid disorders nicely. So the combination of thyroid and obesity again, a pandemic throughout the world, and recent estimates suggest that around 1.2 billion population in the world is suffering from obesity, some kind of overweight or obesity, and Pakistan being no exception. Especially the Southeast Asian countries, Middle East countries, they are in fact at the tip of whatever is happening around the world. So it's very important to know what is the relationship between thyroid and obesity. So in today's presentation, I would like to see what the literature says, what the common understanding is, what the research has up till now told us about. Is there any relationship between thyroid and obesity or not? If yes, how to deal with it? How can we go about it? And to make our healthcare professionals aware about it. So can you please change the slide? Okay. So these are my declaration. Nothing to declare. Next, please. So in today's presentation, next please, what I'm going to discuss in the next half an hour, to explore the bi-directional relationship between thyroid dysfunction and obesity, as the title has already said. Next please. Then we are also going to see how can we differentiate between true hypothyroidism and obesity related alterations in thyroid function test. Plus, next please. In the end, we are going to discuss the evidence-based approaches to the management of obesity in patients with thyroid disorder. So this is what we are going to discuss in the next 25 to 30 minutes. Next, please. So this is World Thyroid Day, May 25, coming tomorrow. So let's discuss. Next, please. So thyroid and obesity, not a simple equation, not easy to understand. Most of the time what happens, next please, whenever a person who is obese or overweight comes to our clinic, or a person with thyroid comes to our clinic, the first thing that we all think, oh, this obesity or this overweight is because of thyroid disorders, because we know the main function of thyroid hormone is to keep the homeostasis in the body right, to keep the basal metabolic rate right. So it is not unusual to think that if there is a imperfection in thyroid function test, this is the culprit, this is the one that is causing all the weight. But what we are going to discuss, is it always just the thyroid, or there is more to it that we should be looking at it? Is there anything that we are missing? So thyroid and obesity goes hand in hand, especially if you talk about hypothyroidism. But how much to blame thyroid for it, and how much we should be looking at other subtle signs and symptoms? Are we missing something? Are we ignoring something? This is what we are going to talk. Next, please. So we all know the health consequences of obesity, nothing new. It's affect the whole body from head to toe. Many endocrine abnormalities are associated, including thyroid dysfunction. If you talk about cortisol, if you talk about other hormones, growth hormone disorders, acromegaly, directly or indirectly, they are affected. They present like obesity. So obesity in itself can cause all these complications, from idiopathic intracranial hypertension to stroke to pulmonary diseases, liver, GI, joints, muscles, you name it, and the complication is here. So on top of it, if there is thyroid along with this, so you can just imagine the amount of complications and amount of problems that this can cause. Next, please. So what is the link between thyroid and weight? If you just remember the pathophysiology or the normal physiology of thyroid gland, you'll just remember that thyroid is basically involved in the regulation of metabolism and energy expenditure. We all know that the thyroid hormones T3, T4, they are responsible for maintaining this homeostasis. Hypothyroidism, that is decreased thyroid hormone levels in the body, can lead to weight gain and difficulty in losing weight. Similarly, hyperthyroidism, that is overfunctioning of thyroid gland resulting in excessive thyroid hormones, may result in unintentional weight loss. So weight and thyroid goes hand in hand. There are no two things about it, nothing to debate about it. They are part and parcel of maybe different spectrum of one thing. Next, please. So increased metabolic activities of almost all tissues of the body are the function of thyroid hormones. Then BMR can increase to 60 to 100% above normal when large amount of these hormones are secreted. Similarly, when no thyroid hormone is produced, basal metabolic rate falls to almost 1/2 normal. So this is what the normal physiology is. Next, please. So there was a Danish study, in which they have found that previous slide, please. Previous slide, please. Okay, so this is a cross-sectional study of more than 4,000 patients who did not have thyroid dysfunction. But you just imagine, with the increasing in BMI, their thyroid hormone levels also increase, although they are in the normal levels. But if the BMI is low, the thyroid normal range of thyroid function is different compared to those who are having a high BMI. Next, please. So the researchers have worked for it. What is the reason? So there is adipose tissue in obesity. There is more adipose tissue, so it becomes metabolically active. which results in release of pro-inflammatory cytokines, which interferes with insulin signaling pathways, ultimately leads to activation and reduction of insulin sensitivity. So, no matter what the disease process says, insulin sensitivity, insulin resistance comes and plays a part. Nowadays, you must have heard MSLD and liver problems and GI and gut. So every organ is affected by this weight, by this obesity, by this overweight, thyroid being no exception. So this is how this is functioning. Next, please. So adipose tissue is a very active body. So how obesity impacts the thyroid function? You know, it has got inflammation effects. So when a person is obese or overweight, it leads to a state of chronic inflammation, which can impair the thyroid function. And these inflammatory cytokines can then disrupt the synthesis and secretion of thyroid hormones. Then there is hormone resistance. You know, increased fat tissues can cause resistance to these hormones, which may lead to elevated levels of TSH. Then thyroid hormone health, obesity is also associated with altered levels of free and total thyroid hormones. Weight gain can result in lower levels of free T3 and T4 hormones. So all these leads to metabolic implications, which is thyroid dysfunction due to obesity can contribute to metabolic syndrome and increase the risk of cardiovascular disease and diabetes. So it's not just a cosmetic issue. You know, the weight, which is because of the thyroid dysfunction, can have much serious consequences in terms of cardiovascular and long-term complication. So thyroid issues can also complicate the weight loss efforts that the patient is going through. Individuals who are trying to lose weight, but if their thyroid functions are not normal, all these efforts will not bore the result that is expected of them. Next, please. So let's talk if there is no thyroid problem as such, what the overweight and obesity contribute to these thyroid dysfunctions. So obese patients have increased TSH or peripheral thyroid hormone levels without any thyroid disease. It's a known fact. Then thyroid dysfunction is also associated with changes in body weight and composition independent of physical activity. Again, all those who are treating thyroid patients, they know that weight gain often develops after treatment of thyroid dysfunction in hyperthyroidism. We know that hyperthyroidism itself causes weight loss, but once you treat it, patients gain weight and sometimes more than what was initially there. So again, both subclinical and overt hypothyroidism are frequently associated with weight gain. So these are some of the normal mechanisms that occurs. Next, please. So these are some of the, one slide back, please. Okay. Okay. Next, please. So these are some of the genes and next, please. Okay, so these are some cis-acting sequences and trans-acting factors. Thyroid is at the lower end. Then you can see anterior pituitary and hypothalamus. So there's a whole cascade that takes into account whenever there is a problem with the weight of a person. Next, please. Okay, so as we have seen in the previous slide, all these factors lead to insulin resistance, which can disrupt this process, leading to reduced hormone production. In obesity, again, as we have seen that peripheral conversion of thyroxine to T3 is impaired, altering the T3 and T4 ratio, which again is important in the management of weight in these patients. Then there is a role of leptin. Leptin resistance is there, which makes the body less sensitive to leptin's effects, resulting in excessive appetite and reduced satiety, ultimately disrupting the energy balance. So on one hand, there are thyroid hormones which are directly affecting the efforts of losing weight, promoting increased weight. On the other hand, it is promoting insulin resistance, which all has its consequences. Then secondarily, it has got leptin resistance again, leading to reduced satiety and disrupting all the energy balance. Next, please. So what is the role of leptin? TSH levels are increased or slightly upper limits of normal in obese people and positively correlated with BMI. Next, please. So there's a brief about how leptin and body weight coordinate and how they affect. All these things are important to understand so that when we manage these patients with thyroid disorders, especially those who are struggling with obesity or weight loss, so you should have a clear idea that what are the mechanisms, what are the pathophysiology that is occurring at the back of all these things so that we can manage them properly. So in obesity, there are so many adipocytes, they produce leptins. It regulates energy homeostasis by informing the CNS about adipose tissue reserves. So it also modulates the neuroendocrine and behavior responses to overfeeding, regulating food intake and energy expenditure, which is kind of behavioral therapy that we target once patients are unable to lose weight. Leptin is also a neuroendocrine regulator of the hypothalamic pituitary thyroid axis. You know, there's a complex relationship that occurs to keep things in a smooth fashion. So leptin again is one of the neuroendocrine hormone regulator, which is affecting all these things by regulating TRH gene expression in the paraventricular nucleus, which leads to TSH. In turn, will stimulate the leptin secretion by human adipose tissues, and the leptin also affects the thyroid deiodinase activities with activation of T4 to T3 conversion. Next, please. There is also a debate whether autoimmunity contribute to obesity or whether there is a link between autoimmune thyroid disease and obesity. So there's a study, although an old one, but it has shown that autoimmunity in obesity in children it was around 12.4% and in adults 10 to 60%. So the prevalence of overt and subclinical hypothyroidism was around 19.5% in 144 morbidly obese individuals. So it directly or indirectly also affects the all these changes. Next, please. Now, this diagram just tries to tell you how all these mechanisms are interconnected. No? On eating disorders, we know obesity, weight gain. One aspect is the eating behavior, the satiety centers, the neuroendocrine hormone, the thyroid hormone, and there are so many others that some of them are discovered, some are yet to see. There are satiety center, there's hypothalamus involvement, there is pituitary gland and thyroid. So what happens that appetite regulation, which influences on feeding behavior, food intake, and expression of hypothalamic appetite regulating peptide. Okay. So there are two disorders of eating behavior. One is anorexia nervosa and the other is bulimia nervosa or binge eating. Both of them can directly or indirectly lead to obesity. So when there is regulation of appetite which is disrupted, there is energy balance which is also not as per the regulation it should be, leads to mood regulation. There are swings of mood, influence on serotonin and norepinephrine and neurotransmission. So you can see it's a very, very complex mechanism. In anorexia nervosa, there are decreased TSH, decreased T3, decreased TRH, while in bulimia, you can see T3, T4 may be decreased, T3 increased, and TSH may be increased. So all these goes beyond just what is seen physically. On a micro level, on a genetic level, cellular level, neuroendocrine, brain level, all these changes are occurring, which is leading directly or indirectly to the weight that we see so commonly in patients with hypothyroidism. Next, please. So metabolism drop, we know, it's involved in the doing of metabolism. So whenever there is hypothyroidism, there will be decrease in thyroid hormones, which is very essential for regulating the metabolism. Then increased fatigue, a common symptom that we all see as the metabolism slows. Patients with hypothyroidism usually complains of tiredness, of increased fatigue without any obvious reason, which further contribute to weight gain. Plus, there is fluid accumulation. You know, patients might present with edema. Hypothyroidism, we know, it has the ability to retain fluid, which may lead to swelling and again weight gain. This fluid retention is often mistaken for fat gain, so complicating weight management efforts. So on the one hand, there is decreased metabolism. On the other hand, there is increased fatigue. So patients are not physically active. plus there is fluid accumulation, and there are other mechanisms which leads to weight gain in patient. All these combination of these processes will ultimately lead to weight gain that we see commonly in hypothyroid patients. So we need to address all these factors whenever we are treating patients with thyroid disorders, especially hypothyroidism. Don't just look for their thyroid levels and normalizing there. Of course, this is the main arm, but we have to look beyond that. So if you are aware of these mechanisms taking place underlying, only then we are going to look for it and do something about it. Next, please. So, what about children? There is data in overweight and obese children. So, overt hypothyroidism, normalization of TSH has no significant effect on change in body weight. And efforts to reduce TSH in this group of patients can lead to iatrogenic subclinical hyperthyroidism. So, this is a word of caution. We know why, while hypothyroidism is associated with weight gain, but if the weight gain is not just because of hypothyroidism, there are other reasons. Once TSH has normalized, and if the weight is not coming to normal, please look for other reasons. Don't blame everything on thyroid. We know it plays a part, it has got its role, but again, it's a bi-directional relationship. So sometimes over treatment of these children or even adults can lead to subclinical hyperthyroidism. So we need to avoid this thing. Next, please. So it is important to know where to stop and when to do. So obese children with isolated high TSH, that there is no need for thyroxine treatment. The treatment is required only in overt hypothyroidism, and the cutoffs are different for children and adults. Similarly, subclinical hypothyroidism is not an indication to treat obesity. Obesity may not be because of that subclinical. That mild derangement may be just because of obesity, and we need to target obesity. Decreasing the weight, and after weight loss, this TSH usually comes back to normal, whether you use thyroxine or not. So in these patients, in these children especially, you may not need to use thyroxine. Otherwise, you are going to produce subclinical hyperthyroidism. And the European Thyroid Association guidelines and the ATA guidelines, they all say that in obese patient, TSH levels between 5 and 7 are the result of excess body weight. They are not generally hypothyroid. They do not need treatment. We have to look for obesity, other causes of obesity, and have to target obesity as such, and not labeling everything on thyroid disorders and hypothyroidism. Next, please. This point is very important to remember. So if there is thyroid dysfunction like subclinical, should we be treating that thyroid dysfunction? So in 1940s and 50s, first attempts were made to induce weight loss in obese with thyroxine. After the observation that hyperthyroid patients who decreased their body weight by 15% in the course of the disease. We know that hyperthyroidism, one of the important manifestation is weight loss. Patients usually present with weight loss. After that investigation, they are diagnosed that having hyperthyroidism. So people thought if more thyroxine is causing weight loss, can thyroxine be used as a weight loss medication? But it has been shown that in physiological doses, thyroxine therapy resulted in muscle wasting and weakness and adverse cardiac effects due to subclinical or overt hyperthyroidism. While thyroxine is a life-saving substance compound, should be given to those who really need it, like overt hypothyroid patients or subclinical. There are certain indications when to treat those subclinical patients. But just because of obesity with normal thyroid function or subtle abnormalities in thyroid function, there is no indication of using thyroxine. In fact, you'll be doing more harm rather than doing good, as the studies have shown that results in muscle wasting and all other problems and weaknesses. Next, please. So does weight loss have an influence on thyroid function? We have seen that obesity causes subtle changes in TSH levels, T3, T4 levels. So is the opposite also true? So yes, weight loss can be achieved by lifestyle interventions, pharmacological treatment, bariatric procedures, or a combination of them all. The important thing is you need to know when to look for it, how to address it, and how to take care of it. In studies based on lifestyle interventions, that is diet combined with increased physical activity, a decrease of fat mass was associated with a decrease in TSH levels from 2.8 to 2.2. So in the normal, if the TSH levels are normal, or if they are mildly increased, there is no indication of treating those subclinical TSH levels for the treatment of obesity. Only the clear-cut indications for thyroxine treatment should be followed. Next, please. So in sometimes metabolic, if there are non-specific symptoms of true hypothyroidism, like lassitude, fatigue, slight anemia, constipation, these are very common, we know. But thyroid hormone therapy should be avoided in patients with no biochemical documentation. These subtle signs, they may be a reason for any other underlying cause. Look for anemia, look for other reasons, maybe B12 deficiency, folic acid, other micronutrient deficiencies for these non-specific symptoms. If the thyroid functions are normal, there is no biochemical abnormality, thyroxine should not be used for just mild, subtle thyroid functions abnormalities. Next, please. However, having said that, main indication for use of thyroxine can be subclinical hypothyroidism with hyperlipidemias in case or addition of T3 in cases of patients with adequately substituted hypothyroidism. Obesity which is resistant to lifestyle intervention or suspected of thyroid hormone conversion disorder. These are very few and very rare causes. Most of the time it's not. If the obesity in the first place is not because of thyroid disorder, thyroxine is not going to do anything. But if there these subtle abnormalities, there are other compelling indications for the use of thyroxine. Some of them is written here. There are more, for example, in infertility cases, in pregnancy, all those other conditions, then of course you have to use it. But just for the sake of mild TSH level raised and obesity, there is no indication for use of thyroxine in those patients. Next, please. Next, please. So the big question is, when should the treatment of obesity in thyroid disease begin? This is a very nice review article recently published, and it has very nicely documented the whole evidence and when we should be looking. Ideally, whenever a patient of thyroid disorder, usually hypothyroid, comes to your clinic and he or she is either overweight or obesity, we should be focusing on weight as much as their thyroid dysfunction. So the day one is the time. It's just like in diabetes, when should we be looking for complication? Is the day one when the patient has come to you for the first time. Maybe he or she is not aware of it. There might be some complications already present. So here also, although the person is diagnosed with some thyroid disease, but there might be underlying other reasons for this obesity. That is why so many times when the physicians blame all the obesity and the patients also to the thyroid, once the thyroid is in the normal range and the patient is not losing the weight, then the big question mark remains, now what? So we should always be open for other options. We should always be looking for other reasons. Having said that, thyroid itself cause obesity. We know treatment of thyroid dysfunction will lead to sometimes normalization of weight if there was no other concomitant problems. But again, the other possibility should always be there, should always be looked for, and we have to keep that in mind. Next, please. So again, obesity, thyroid dysfunction, metabolic syndrome, these are all linked together. Another very nice article published recently last year, you can all go through it, and it has very nicely defined. Next, please. It's a graphical representation. Next slide, please. There's a cardiometabolic risk, and at the baseline, you can see thyroid dysfunction. So thyroid dysfunction leading to inflammation and oxidative stress, as we have discussed earlier, leads to AKT activation, lipogenesis, leptins, These are all responsible directly, indirectly, leads to the dysregulation of fatty acid, beta oxidation, cholesterol, biosynthesis, resulting in dyslipidemia, obesity, and insulin resistance, and ultimately cardiometabolic risk. So in thyroid, we should not only be focusing on obesity, but obesity with all its accompaniments like dyslipidemias and ultimately cardiometabolic risk factors. Next, please. So, should we treat thyroid dysfunction in obesity? So, in supraphysiological doses, I've already mentioned thyroxine therapy resulted in muscle wasting and weakness and adverse cardiac effects. So, if the dysfunction is because of obesity and not purely because of thyroid dysfunction, do not prescribe thyroxine for them. Next, please. So how do we address the weight? How do we manage weight in these patients? First of all, you need to be very clear about your targets. Your goal of treatment is that the patient with primary hypothyroidism, their hypothyroidism should be corrected. That is, TSH concentration should come back to normal. This is our number one goal. An early clinical response in moderate to severe hypothyroidism is a diuresis of 2 to 4 kg. So when thyroid functions are normalized, TSH goes in the normal range, there is 2 to 4 kg weight reduction, which is because of the response, the diuresis response. Then expected weight loss once the treatment of hypothyroidism begins is very small, most often less than 10% of the body weight. So treatment should result in a return of body weight. If the obesity was because of thyroid dysfunction, then ideally, once thyroid hormones are in the normal range, this weight should again be in the range before the development of thyroid disorders. If this is not so, then this is the time that you should be thinking about other ways of managing this obesity and not blaming only the thyroid hormones, only the thyroid gland for all the obesity, because obesity is so common, not only in the whole world, but in our part of the world. Every third, fourth person is either overweight or obese. So it's very unnatural to blame all the obesity to thyroid disorders. So they do go both hand in hand, but always look out for other subtle signs and symptoms telling you that look beyond thyroid for other weight. Next, please. So what are the management strategies that are available? Number one, like in any other obesity case, treat thyroid obesity also as a case of obesity in any other condition. Plus, of course, you have to normalize the thyroid hormones as well. So behavioral therapies in obesity and hypothyroidism have proven benefits, effects. Then, of course, calorie reduction and increased energy expenditure, again, in any type of obesity, similarly in thyroid related. Nutrition, we are what we eat. It's a very commonly used quote which is, so this is so true. So it leads to weight loss and potential improvements in thyroid gland function as well. Next, please. So we have got various lifestyle changes that we always discuss whenever a person with obesity problem, weight problems comes to us. We do tell them about regular exercise, about lifestyle adjustments, healthy eating, and stress management. These factors not only directly affect the weight, but they improve the thyroid functions as well. So strength training, but if the person is having joint problems, something, then you have to modify the exercise as per their lifestyle. Healthy eating is nutritious, whole wheat. If you involve a clinical dietitian with you, focusing on persons needs and requirements, which limits the processed foods, and increase intake of course, fruits, vegetables, whole grains, and lean proteins. So whatever the things of healthy eating, it should be part of it. Stress management affects not only the whole behavior therapy, your dietary habit, your satiety centers, mindful eating, directly or indirectly affecting your hypothalamus, your satiety centers, appetite centers, in turn improving your thyroid functions as well. So these are small maybe if you see, it might not be looking a very great achievements, but these small subtle changes in your life are going to make the big difference if the obesity is not because of just thyroid. Next, please. So the dietary recommendations that are given, we have to think about iodine sources. We have to tell our patients about it. Selenium benefits in thyroid, their very well-known effects in thyroid hormone metabolism, which is usually present in nuts, fish, and eggs. Zinc is very important. So tell your patients about the sources of zinc, which includes meat, shellfish, legumes, and wheat and seeds. Some of the things are commonly available. Then balanced diet again. Uh, you cannot emphasize enough about the importance of balanced diet, about physical activity, about stress management, about behavioral therapy when you are addressing obesity or managing the weight problems. Next, please. So basically, exercise again, not only for weight loss, for weight maintenance, it also supports the overall energy levels, and it helps in insulin sensitivity, which we have seen was one of the basic disruptors leading to all this weight. Stress relief again important, and physical activity promotes the balance of thyroid hormones, which are crucial for metabolic processes. So it is important to transmit all these things to the patients, tell them how it is going to help them. Next, please. So just like in any other obesity management, after lifestyle modifications, dietary modifications, physical activity, we have got some pharmacologic agents and surgeries. You know, incretin therapies, especially GLP agonists, are now commonly used in the management of obesity. Now, there might be some concern, especially in patients with thyroid, because we know there is a risk of developing very small percentage of medullary thyroid carcinoma, but it's not very common. So maybe in those patients who have got a history or a family history, you'll be cautious, but otherwise you can safely use GLP agonists with very good results in the management of obesity. And if there is morbid obesity, then bariatric surgery again have got very good results. So the basic take home message is, yes, although thyroid hypothyroidism can cause weight gain and obesity, not all obesity is because of thyroid disorders, and we have to have a multidisciplinary approach in managing these patients. On one hand, addressing their thyroid dysfunction, on the other hand, looking at the obesity not just from thyroid point of view, but as a separate entity, so that long-term complications can be avoided. Next, please. So incretin therapies are commonly now being used in the management of this one. So just to summarize the whole this debate of thyroid and obesity, we know there is a strong bidirectional link between thyroid and weight, and it plays a very crucial role in regulating the body weight and metabolism. And any imbalance can lead to weight gain. The metabolism impact can significantly slow down the metabolism, making it difficult to maintain a healthy weight, which again lead to fat accumulation. Then again, thyroid disorders and hyper and hypothyroidism directly affect the energy levels and weight management. So early diagnosis is essential for effective treatment. On one hand, some people attribute every weight gain to thyroid, and on the other hand, sometimes obesity being considered something a norm, thyroid disorders often neglected, undiagnosed, remains for a very, very long time. So we have to look at both times, that thyroid can cause obesity, and obesity can be hiding underlying thyroid disorder. So health management is important. Obesity strategies, well known, they should be implied, they should be looked at. Next, please. So, given frequent issues with obesity in patients, early interventions with a comprehensive approach to obesity management seems reasonable. It is justified by the proven cardiovascular benefit. You know, we should not be looking obesity as a cosmetic reason, but long-term cardiovascular benefits, which includes improvement in lipid metabolism and blood pressures. Choice of therapy and intensity of intervention depend not only on the degree of obesity, just like all the algorithms tell us when we deal any patient with obesity, but also on the comorbid conditions, especially the vascular complications, underlying thyroid problems, and especially the previous attempts by the patient of losing weight should also be taken into consideration when you are making a plan for them, so that how much progress they have made in the earlier ones, so that you can move to the next step rather starting from zero. You should know what are the things that the patient has already done, so that you can move to the next step. Next, please. So this is just for the thyroid dysfunction in obese patient. If a obese patient comes to you, TSH, you order TSH. If it's more than 10, then of course T4 is low. You have to give thyroxine supplementation, which is overt hypothyroidism. If it's in the normal range, whether symptoms or no symptoms, look for secondary hypothyroidism. If there is no such thing, you do not need any treatment, whether obese or non-obese. If the thyroid functions are normal, no treatment with thyroxine. The case comes when the TSH is less than 10 but more than the normal. Then evaluate for symptoms and free T4 and look for antibodies and look for other comorbidities, and make the patient fall into any of the categories and then treat accordingly. If it's in the normal FT4 in the normal range with no comorbidities, no treatment is required. But if there are autoimmune disorders, there are other conditions along with this, then you might consider thyroxine therapy. There are very specific indications in which you can give thyroxine in subclinical cases, not just for the treatment of obesity, but for the prevention of long-term complications. Next, please. So this is the last slide. Just to summarize, weight dynamics are integral part of thyroid dysfunction. Crucial metabolic derangements are closely interlinked between main endocrine organs, adipocytes, and thyrotropes. So it's not something in isolation. The whole body works in sync with one another. Large epidemiological studies are lacking and requires research of intensive results. Whether simple obesity, we can do that. Up till the research, whatever we have, it's not promoting the use of thyroxine in just for the sake of obesity. Lifestyle interventions remain essential component in all weight management strategies, whether it's because of thyroid or any other condition. Next, please. So the take-home message is, look out for thyroid disorders in obese patients, but do not attribute all the obesity to thyroid. Look for other causes, look for other reasons, and try to address it as you address obesity in any person. Thank you so much. Okay, can PCO syndrome be added in this? Yes, of course. Obesity, there are. Can we still use Ozempic if family member with confirmed thyroid cancer? You know, it's basically about the medullary thyroid cancer. So you'll be very cautious about it. Find out what type of cancer was it. So I will be a bit apprehensive using it if I know the details about it and it was not medullary, then yes. And we'll just evaluate the person presenting to us, then maybe you can go with it. Can Ozempic be used in case of what? In cases of obesity with thyroid dysfunctions, yes. Not Ozempic, is basically GLP-1, those which are licensed for obesity use. There are other, it's not basically Ozempic, it's a brand name, it's other GLP-1 agonists which are used for the management of obesity. You can use that. PCOS can also be addressed in the similar manner. I hope it answers your questions. If no more questions, Dr. Sadia, would you like to have some concluding comments or your opinion?
First of all, Dr. Musarat, it was a wonderful presentation, and the topic was complicated, but you clearly mentioned each and everything, when to treat, when not to treat. So the things were very clear in your presentation. The important thing, I think everyone was confused about the use of semaglutide, GLP-1
Yeah.
agonist, and the thyroid because of the cancers, but you have cleared all these things that it is only the medullary thyroid cancer, not the other cancers, and not only the thyroid problem. So we can safely use semaglutide or GLP-1 agonist in the treatment of hypothyroidism and obesity. Again, thyroid is not causing that much weight gain. We cannot blame the thyroid like this, that if there is a moribund obesity, and we cannot say that it is all due to thyroid. The important thing is when to treat and when not to treat. I just want to, you have clearly mentioned all the things. One thing, it is if the hypothyroidism, it is clear TSH is more than 10 or it is overt hypothyroidism, like TSH is raised and T4 is low, so it is hypothyroid. You have to give thyroxine. But the problem lies when it is less than 10, and you have clearly mentioned it. In less than 10, and the most important thing is when it is less than 7, 6.9, between 5 to 7.
Mhm.
That is the problem zone. If the patient is obese and the TSH lies between the upper normal range and the 7, that is again the problem zone. There we have to treat or not. That is very important because it causes subtle changes in the thyroid. Obesity causes subtle changes in the TSH. So at this problem, subclinical hypothyroidism in this range, so decision lies here. We have to treat it or not. So again, if there is a problem, lies if autoimmunity is present, anti-TPO antibodies are positive, or if there is fertility concern, then the guidelines are different. As you mentioned, if there is hyperlipidemia, fertility, anti-TPO antibodies positive, then in these cases, yes, maybe under 7 we can treat that. But otherwise, if it is only obesity and TSH is under 7, then we can just observe. And the beautiful thing is that with the lose of weight, when you will repeat this TSH and it will come back to the normal. So
Yes.
that actually this is the gray zone. The other things are very clear, but this is the gray zone between 5 to 7. Like you shared a study of the children with obesity, the TSH rises between 5 to 7.
Yeah.
But again, if anti-TPO antibodies are positive, autoimmunity evidence is there, or there are certain other things like you mentioned, then in this zone. Otherwise, the rest of the things, like if the TSH is more than 10 and patient is obese, then it cannot be obesity-related dysfunction. It is obesity and thyroid as well. So you have to
Yes.
treat both side by side, hypothyroidism as well as obesity. And you touched everything of obesity management as well, starting from the lifestyle modification till the drugs, and everything went very well.
Okay, thank you so much. I think the message is clear, yes. And the one thing that I want to emphasize, the treating physician, nobody can replace that person. The one who is treating the patient, who knows each and everything about the patient. So when to treat, whether to treat or not to treat, it's something, it's the consensus. The guidelines are here to guide us, but then there are certain areas in which the physician has to take a decision. So sometimes you might want to give a trial if you are sure that this is because of the thyroid disorder. Dr. Azra, I think you have
Yes.
joined back.
Yeah,
Yeah.
sorry, I just got
No, it's
disconnected
fine.
right when I was going to just compliment you. You have very elaborately described everything and the relationship between thyroid, hypothyroidism, the inflammatory markers that are secreted when there's obesity, and that can lead to a little bit of thyroid dysfunction. And yes, it's the gray zone that Dr. Sadia was pointing out. It becomes a dilemma because a lot of patients, they read up on this and say, okay, my metabolism is slow, तो थायराइड तो लेनी पड़ेगी, थायराइड हार्मोन और ये सब चीजें. As you said, there's no harm if we can give a small trial and then call them back in 3 months and see if things have improved, even when there were mild derangements perhaps in TSH, and then you can discontinue it depending on the results. And once you have the
Yes.
anti-TPO antibody status and things are more clear. क्योंकि अगर
Yes.
small dose if we give of thyroxine, it's not going to harm in a young patient in most cases,
Yeah.
right? So yes, that's there. Can you see any questions in the question link?
I have
So,
already answered. Yes, there were 3, 4 questions. So I have answered those questions. It
all
was
right.
about the use of GLP-1s. So
Yeah.
they have asked about a specific brand name. So that brand is not licensed for obesity management in any patient. So yes, GLP, but those which are licensed for obesity management can be used in thyroid as well.
Right. Right. And it's very important that, if somebody has primary hypothyroidism, true primary hypothyroidism and obesity, you see that, when they lose weight, their thyroxine requirements may go down because
Go
usually
down.
thyroid replacement is weight based. So we do see that a lot. So it's very, very important, as you very rightly mentioned, that weight loss is very important in many, for everything, for the entire body, for prevention of diabetes, hypertension, dyslipidemia, and also for keeping your thyroid levels normal. Otherwise, we'll have to keep on increasing the dose if the patient becomes more and more overweight.
Yes, yes.
All right. Thank you. I would like to.
I think there's more because let me see.
Okay.
With confirmed thyroid cancer. Okay, it's the same questions. We have answered all these. Yes. Thank you.
All right. Thank you so very much. Again, Dr. Musarat, for your elaborate presentation, Dr. Sadia for your valuable comments. And I'm sure the participants have really learned a lot from this webinar. Let's kind of translate this into clinical practice. We know we have all the evidence with us, and to better manage our patients, right, in a more evidence-based manner. Thank you so very much, everyone. And
Thank you.
that's till our next webinar, inshallah. Allah
Thank you.
Hafiz.
Thank you. Allah Hafiz.